this computer. It looks different. It looked different because the other one didn't say that. So it's going to
now.
Okay. So when we talk about increased intracranial pressure, make sure there's nobody else waiting to get in here. Okay. When we talk about increased intracranial pressure, the brain works on what's called the box theory. And the box says that inside the brain, it's a box. It's an enclosed cavity. And there's only so much room inside of the box. And it contains three things. It contains your brain tissue itself, which takes up most of the room in the box, which is about 78%. It includes your blood that flows through the brain, and it typically has a consistent amount of blood flow that goes through it. And then it has cerebral spinal fluid of about 135 mLs, and that takes up about 10%. And that is what is in the brain. The Monroe-Kelly doctrine says that if you increase any one of these three things without decreasing one of the others, then you will have increased pressure within the box. Pretty simple, huh? And the blood and the cerebral spinal fluid actually gives you the ability to increase or decrease. So if like you were to get a brain tumor, there's a little bit of wiggle room. You could shift some of your cerebral spinal fluid down into your spinal column and make a little bit more room up in the cranium and not necessarily have increased intracranial pressure. So there's a little bit of wiggle room, a little bit of compensatory mechanisms there. But as a whole, there's not a whole lot of wiggle room, but there is a little bit. So we can always do a little bit. But the Monroe-Kelly doctrine says that if you increase one of these without decreasing the other, you will get increased intracranial pressure. Now, the normal intracranial pressure is between 5 and 15. So anything greater than 15 is considered abnormal at your head up 30 degrees. Right? So that's kind of what we consider normal. 30 degrees is how we measure it. If it's greater than 20 and is sustained at greater than 20, then you have a very poor prognosis. So if it's between 15 and 20, it's abnormal, it's elevated, but probably you could live with that and not really have a lot of problems. But if it's greater than 20 and it stays that way, you probably will have problems. Now, measuring ICP is not easy. It's not like you take a Sphygmo and you put it around somebody's head and pump it up and say, oh, look, this is what your ICP is. In order to measure this, we have to drill a hole into your skull, put some kind of catheter either into your ventricles or into your subarachnoid spaces or your epidural space or in the brain tissue itself and measure it. So this is not a measurement that's very easy to obtain. It's very difficult to obtain. So that should tell you that you were only doing that when it's absolutely necessary that we get these measurements to guide treatment. So it's not a measurement that we get real easily. It has to be justified to drill a hole in somebody's brain and stick a catheter in there. All right. So what causes, we all have transient increased intracranial pressure. We all have times that our ICP goes up, but it usually comes right back down. So we're always able to tolerate ICPs that are very high that come right back down and we don't die. For example, our blood pressure can shoot up. I bet on test days, all of your blood pressure is a little bit up, and not, to my knowledge, not one student has dropped over dead during a test. Maybe, but I don't think so. I've never seen it happen in 20 some years. So if your blood pressure goes up, your ICP is going to go up. And so, but then when your blood pressure comes down, your ICP comes down. So you could have a fight or flight, get scared and your blood pressure shoots up. And so your ICP shoots up, but it's going to come down and your body's made to handle transient. Intra-abdominal or intrathoracic pressures increase. Intra-abdominal is when you Valsalva, when you poop. Now, we all poop. Whether you like to admit it or not, we all poop. It killed Elvis. Elvis died on the pot. You'll probably barely know who Elvis is. But anyway, it killed Elvis. We all, when we poop, we Valsalva. It's a problem. But very few of us have a stroke or die on the toilet. When you vomit, you increase your intra-abdominal pressure. But most people don't vomit and die. Your intrathoracic pressure, when you cough when you sneeze. Have you ever sneezed a bunch in a row and then see stars? That's because you increased your intrathoracic pressure from sneezing, and then a bunch of them in a row caused you to increase your intracerebral pressure. And this caused you maybe to see a few stars because your ICP went up, but your ICP came on back down and it did not kill you. So those are things that can cause an increase in your ICP. Posture, blood flow. If you increase your blood flow to your head, you're going to increase your ICP. But little kids that go to the jungle gym at the park and hang by their knees for 30 minutes, hang upside down, their head gets all red and they look like they're going to die, but they don't die at the jungle gym. They sit there, but blood does increase flow to your head when your head is down. And so typically, if you put your head up, blood flow will go out of your head, and that will decrease, that will make room in the box. So just putting your head down will increase your ICP. Putting your head up will decrease your ICP. So if you sit with your head lower than your body, it will increase, and you will have transient ICP. Hyperthermia and hypothermia, actually both of them can cause transient ICP. So both of them, so temperature extremes, we don't want temperature extremes in either one of them, can cause it. Right. And then hypercapnia, remember that's increased CO2. CO2 is a vasodilator. And so when somebody becomes hypercapnic, it will cause vasodilatation, and this will increase their CO2. And that will increase their vasodilation, which will increase their ICP. So your respiratory system can cause an increase in your ICP. So how do we do? So how does the body compensate? Transient, it just goes away. But some people have prolonged ICP increases. So the body still it doesn't die right away. You're starting to develop a brain tumor. You don't drop dead the minute your brain tumor starts, or you may have hypertension for a long period of time and you still don't die right away. So what does the body do? Well, it starts to compensate. It does something to make more room in the box. Well, the first thing it can do is it can displace some of that cerebral spinal fluid out of the brain and stick it down into your spinal column. It's one of the exits out of the brain. And so that will put less into the brain and put it down into your spinal column. It can increase the outflow of blood from the brain. So it can cause a little vasoconstriction and shoot the blood out of the brain. And when you shoot some blood out of the brain, you're going to have more room inside of the box. Okay? It can also just not produce as much CSF. Just say you don't need as much. The box is full. Don't make as much CSF. And then not just venous outflow, but it can cause arterial vasoconstriction. And that will make more room in the box. Now, if arterial constriction, the artery side, is constricted for a long time, like over a longer period of time, like from hypertension or other problems, you're going to have consistent decreased blood flow to the brain. And if you have decreased blood flow to anything, it can become ischemic. And you start to lose brain cells. So yes, we might be compensating for increased intracranial pressure, but you might start to get ischemic brain because you don't have enough blood flow going up there, because you've got something else, like maybe a tumor or something else like hydrocephalus, if you have too much cerebral spinal fluid up there. And so the body's trying to make more room in the box. So it's trying to change one of the other three things. And it's hard to change the brain mass. So you either can usually only affect either the CSF or the blood flow. So they'll vasoconstrict, make the blood vessels smaller inside the cranium, and therefore you get ischemia. Okay, so you can get ischemia. Now, you can also get, if you have too much pressure inside the brain, and it keeps getting harder and harder, just inside the brain gets tauter and tauter and tauter, you know, more tight, more tight, more tight. Then from the outside, the capillary beds in there start to get squashed from the outside. The brain tissue starts to squash. It's not a vasoconstriction problem. It's the fact that there's so much ICP that it is squashing the blood vessels. And so you can get ischemia because the pipes are getting squashed closed because of ICP. And the blood can't flow through squashed pipes. So if I'm reading where these double asterisks are. If the increased ICP continues, the brain starts to compress, like if the tumor keeps getting bigger and bigger and bigger, like the brain tissue continues, it's going to squash the capillary beds closed from the outside. And when the blood doesn't flow, you'll get ischemia. Okay? Or if the vessels vasoconstrict down and there's no blood flow because not enough blood's going through there because of compression, of vasoconstriction, completely different mechanism, then you're going to get ischemia because of decreased blood flow due to vasoconstriction. So it could be because there's too much pressure, or it could be because there's too little pressure. Once not enough blood flow getting up there, and one is there was so much blood flow that it's squashing it against the cranium. So too much is too bad, too little is too bad. Well, not too bad. Too much is bad, too little is bad. So what do we want? We're like Goldilocks. We want it just right. Okay, we want it just right. We want the correct blood flow to go through there. If I have,
Jay,
yes.
sorry to interrupt. Elizabeth, she's still in the waiting room.
Well, we'll let Elizabeth in.
Thank you.
Thank you for letting me know. Welcome. I don't know if she can hear me yet. Welcome, Elizabeth. Okay, so we want the correct, oh, don't you mess up. I know this. I didn't change your picture, did I? No, it's okay?
No.
Okay, so, yes, it's okay? Okay, all right, good. All right, so we want the correct blood flow.
Okay,
So the body auto-regulates either to increase blood flow or decrease blood flow to keep the correct blood flow. However, if the body is really, really far out of whack, those compensatory mechanisms won't work. Okay, they just don't work very well. So if your ICP gets really, really high, like greater than 40 and stays there, the vasoconstriction and the decreasing of the CSF or the shifting of the CFS, things like that don't work. Or if your blood pressure, your mean arterial pressure gets really, really low or really, really high and stays there, those compensatory mechanisms won't work, which has to do with your hypotension, prolonged hypotension. Hypoxia, hypercapnia. So if your respiratory status is really bad and it's not fixed, the compensatory mechanisms won't work. Or if your brain tissue itself is just damaged, the actual brain itself, it will not work well. Okay. So we need to have the right pressure. We don't want it too low because then we don't have enough blood flow to perfuse the brain. And we don't want it too high because then the brain is squashed against itself or against the cranium and we can't get blood flow to go through the capillary beds. So we want just the right amount of pressure, all right? And so the amount, so these are just some terms, okay? So cerebral blood volume is the amount of blood in the brain at any one time, okay? That's just a term. Cerebral blood flow is the amount that flows through every minute. It's about 50 mLs. Remember that the brain needs two things to live, oxygen and glucose. It can live without anything else. Oh, it does better with potassium and it does better with phosphorus, but it can live. It cannot live without oxygen and it cannot live without glucose. And therefore, how does it get there? It gets there by the blood, the circulating blood volume. If I don't have enough circulating blood volume getting up there, then my brain will die. I have to have adequate circulating blood volume getting up to my brain. And I have to have enough blood pressure. I have to have enough blood pressure to get that up there. And once it gets up there, I have to have enough pressure to keep the capillary beds open, but not so great that it's squashing everything up there. Okay, so the pressure that's necessary to keep the capillary beds open is called cerebral perfusion pressure, CPP. Normal CPP is computed mean arterial pressure minus the ICP, the intracranial pressure. Normal is 60 to 100 millimeters of mercury. Do you have to know how to compute this? Yes, you do. Are you going to be given the formula? No, you are not. Hey, pretty blatant there, okay? So you have to know how to compute this. I've written this all down for you, so if you can't remember, here it is, all right? Now, you can go to 3 or 4 books, and they might have these in different orders, but the mean arterial pressures are all computed the same. Like some might put the diastolic blood pressure later, some will say divide over 3, which is 1/3. They're all the same, okay? So it's the diastolic blood pressure plus 1/3 of the systolic blood pressure minus the diastolic blood pressure. All right? Normal mean arterial pressure is 70 to 105, which is a little bit different. Your blood pressure is a little higher than your ICP is, okay? Not your ICP, is excuse me, is a little bit higher than your CPP is, okay? And this makes sense. If it's really low, this is mean arterial pressure. This is a reflection of your blood pressure. If you're low, you're going to show signs of low blood pressure. You're going to have dizziness. You might pass out. You might have syncope. You might have blurred vision or double vision, diplopia. Okay, so you would have signs of neurologically, not getting enough blood to your brain. If it's really, really high, then you're going to get maximum vasoconstriction, and you're going to have signs of, again, you could have changes in your level of consciousness. It's, again, not enough blood flow. You're going to have neurological changes. Low blood pressure, high blood pressure. Mean arterial pressure is a reflection of your blood pressure. It's what it is. So let's calculate one. The client has a blood pressure of 120 over 80 and an ICP of 15. Calculate the CPP. I know that CPP is mean arterial pressure minus the ICP. So I take my diastolic blood pressure, which was 80, plus my systolic minus my diastolic, and 1/3 of that, which means I divide it by 3. So 120 minus 80 would be 40 divided by 3, and add that to my diastolic. So 80 plus 13.3 is 93.3. That's my mean arterial pressure. Normal being 70 to 105. So my mean arterial pressure is good, which you would know because my blood pressure is 120 over 80. It's normal. It should fall within the normal range, right? But then don't forget to subtract your ICP. That's where most of you are going to screw up. You're going to forget to subtract your ICP. And so this person's CPP is 93.3 minus 15. So their CPP is 78.3, which is between 60 and 100. So it is normal. If it was less than 60, I would have decreased blood flow. If it's greater than 100, I would have too much blood flow. Reflective of pressure. Okay, just put you some numbers. Get your patient with the blood pressure and an ICP in practice. It's very simple. It's just a math problem, but you have to know the formula. That's the difference. Okay, so what's the typical causes of increased intracranial pressure? Well, it's either going to be edema or blood. Edema or blood. Cerebral edema is very, very common. There's lots of reasons why you have cerebral edema. And this is the pathophysiology part. Again, we don't usually test pathophysiology, but you should know what patients are at risk for cerebral edema. I'm not going to ask you, is this vasogenic? Is this cytotoxic? But you should know the patient that's at risk for cerebral edema. Okay, so vasogenic is the most common. It moves from the intravascular inside the circulating bloodstream out into the interstitial fluids, out into the extravascular space, from the bloodstream into the tissues. Okay, you get this from brain tumors. Okay, you get this from abscesses. You get this from taking poisons and that type of thing. It's by far the most common. Okay, and it could go to any intravascular space. The next one is cytotoxic. Anything that is cytotoxic, cytolytic, those are interchangeable terms. Cyto means cell wall. This is due to an injury to the brain tissue itself. And the little liquid inside the brain tissue, when the cell wall breaks open, that liquid is released into the tissues. And so you get cerebral edema. This is what you get when you get a brain injury. Okay, or an anoxic injury, when somebody is hypoxic, or you get it like with chokings or drownings or cardiac arrest, and they get cerebral edema after a cardiac arrest, and that's what kills them. Their heart came okay and everything, but they developed cerebral edema because they were down too long. Good friend of mine's child was 12 years old and choked on a toy. Believe it or not, it was, I won't go into it, I don't have time, but they got the toy out, but he was down for a significant amount of time. And he was up at PICU and he died from cerebral edema. They got him back, his heart came right back, but he was down too long and he died from cerebral edema. So he has like cytotoxic cerebral edema. Interstitial is accumulation in the interstitial space, and it's usually due to an accumulation of cerebral spinal fluid. You see this a lot with hydrocephalus. So we put a shunt in to bypass, so get it out so it has somewhere to go than just to accumulate there. You've learned that in peds. You learn that, yeah, and Jane will talk about some people that have the buildup of hydrocephalus will need a VP, a ventricular peritoneal shunt, or a VA, a ventricular atrial shunt. This afternoon, I think she talks about that. But you also heard about it in peds with kids that were born with hydrocephalus. So cerebral edema is a very common cause of increased intracranial pressure. Now, increased intracranial pressure is increased intracranial pressure. I don't care if it's from a brain tumor. I don't care if it's from a bleed. I don't care if it's from cerebral edema from an anoxic injury. I don't care if it's from having post-op surgery, and you injured the tissues and now you're looking for signs of increased intracranial pressure. I don't care if it's from a cerebral hemorrhage, from a hemorrhagic stroke. Increased intracranial pressure is increased intracranial pressure. No matter what the cause is, you're going to have the same symptoms. Now, you have early symptoms and you have late symptoms. I would like for you to catch me in my early symptoms, because I don't know. Now that I moved to the beach, I don't think I'm going to have you all as my nurse too much. But when I lived in Charlotte, I kept saying, all of you all are going to be my nurses, and I want you to treat me nice. Even if you hated me as your instructor and said, that old witch, I don't want you to be mean to me when you're my nurse. I want you to be nice to me, okay? And say, really, she wasn't that bad. I don't want you leaving me in my poop and stuff. I want you to wipe my butt. Okay, So I want you to recognize early and help me early, not when it's too late to do something for me. Okay. The number one sign of increased intracranial pressure is a change in the level of consciousness. Recognize whether it's confusion. Maybe I don't recognize my family when they come in, or maybe I know you and then I don't know you when you come in, or maybe I don't know where I am all of a sudden, or I don't know, a change in the level of consciousness, or maybe I'm not as alert as I was before because maybe I didn't know who you were anyway. Maybe I had Alzheimer's, but now you can't wake me up as readily. So whatever a change in the level of consciousness is, maybe I went to oriented times 3 to oriented times 2. Recognize that. It is the number one sign. I can't tell you what that will be. It's different for everybody. What was my original level of consciousness? Do you recognize that I have a change in my level of consciousness? It could just be agitation. I may still be able to tell you be alert times 4, but maybe I'm very agitated. That could be a change in the level of consciousness. I don't have to lose one of my times 4 things. Pupillary dysfunction, very important. Early pupillary dysfunction is changing from a briskly reactive pupil to a sluggish reactive pupil. It is not going from a small pupil in one eye to a large pupil in the other eye. That is a very late sign. But every time you've checked them, they've been brisk, brisk, brisk. That didn't seem as brisk as it was before. I'll be back in 15 minutes. I'm going to check them again. I know that's not as brisk. I'm worried. I need to do something about this. Got to get the doc on the phone. Let's get a repeat CT scan. Let's start just give some drugs. Let's see what we need to do about this. Recognizing going from brisk to sluggish. And I'm sure that, I'm not sure, but I'm pretty sure Jane probably said this. You cannot check pupils with the lights on. If you think you can check pupils in this room, you're wrong. You can't do it. You got to, I don't know, turn the light on over the sink or turn the light on in the bathroom or whatever. So you're not walking to the door in dark. Turn the light on over the sink, close the door and come back and check your patient's pupils. Then go back and open the door or whatever you're doing or turn the light on over the bed. But you cannot have a light in the room in full lightness and check pupils. It's almost impossible. Turn the lights off and check your pupils. That is the correct way to check pupils. Muscle weakness. So, squeeze my hands, move your feet, push pulls on the feet. You might find that one side's probably weaker than the other. They might have sensory deficit. They can't do hot from cold. They might not feel you touch them on certain sides. They might have a headache. Now, it says possible headache. The brain tissue itself has no feeling to it. There are no nerve endings in the brain itself. If you've ever seen the movie Hannibal, where he actually takes the skull off the person and he slices off their frontal brain and he fries it up and eats it for breakfast, and you sit there and go, oh, surely not. Yes, the brain itself has no feeling. And Jane will talk this afternoon, I think, about stereotactic biopsies where the patient is awake and they're in there doing all this stuff to the patient's brain while they are awake. Patient doesn't feel that. The brain itself doesn't hurt. So they may not have a headache. What hurts in your head is when the pressure is pushing on the blood vessels. Blood vessels have great nerve endings on them, and they do hurt. So if the pressure is enough that it's pushing on certain blood vessels enough to cause you discomfort, then you will have a headache. If the ICP is not pushing on any blood vessels or major blood vessels to cause pain, you will have no pain. You will not have a headache. You do not have to have a headache with increased intracranial pressure. Some people do, some people don't. It's all depending on what's pushing on what. You might have a seizure. In the early signs, very few people have seizures. It's like less than 10% have seizures early. And in infants, bulging fontanelles are very common. It is a very classic sign in the infant to have a bulging fontanelle. But the number one sign is a change in the level of consciousness. When you've got somebody you suspect has something with their head and they say weird things to you, Sally, come in here, Sally. Who are you talking to? I don't know. I didn't mean that. Yes, they did. They were calling for somebody that's not there. Yes, they were calling for Sally, and Sally's not here. Okay, so how about some late signs? Their level of consciousness continues to decrease to the point that they may even be obtunded or have even more problems going on here. Vomiting. Now, this vomiting has a very classic presentation. We get in a very, very habit of putting nausea and vomiting together. And I even see this in NCLEX questions. I want you to remember that NCLEX books, NCLEX questions were written by human beings. And some of them weren't written by specialists. And I haven't done any in a while, but quite often I like to review books better than I like to write them. I've written some, but it's been a while, probably none for you all, because it's been a while since I've written any, but I've reviewed a lot of them. And so they'll send me, because I make money, they'll send me and say, Jana, will you review this NCLEX book? And I'll say, sure, I'll review it for you. And I'll get to the neuro section all the time, and it'll say, give me a sign of increased intracranial pressure. And it will say nausea and vomiting. And I will mark the nausea out, and I will send it back, and I'll say, this is incorrect. You know, because I'm looking for content. I'm looking for what's right. Increased ICP is vomiting without nausea. There is nothing wrong with their stomach. So they don't sit there and go, oh, I don't feel well. Oh, I don't feel very good. No, it is due to pressure on the vomiting centers in the midbrain. And so they're sitting there and they vomit without any prodromal. There is nothing to say they're going to vomit. It is a sudden onset of vomiting with no nausea associated with it. So they have no idea they're going to vomit. It is pressure on the vomiting centers in the midbrain. It is not in their stomach. So if it's increased intracranial pressure, it will be vomiting without nausea. Very important. Right now, instead of just some weakness, they may have paralysis or hemiplegia on one side, and that they might have impaired reflexes. So if you test the reflexes, one side's not really have reflexes like the other. And now, as if it's really late, which is pre-herniation, meaning pre-bad, really bad, they will develop what's called Cushing's triad. Now, Cushing's triad is an alteration in their vital signs and respiratory irregularities. Okay, so I'm going to go to the next slide, and I'm going to explain Cushing's triad to you. Now, Cushing's triad is what's called pre-herniation triad. Pre-herniation is when the brain bursts outside of the box, when it herniates outside of the box, which means you usually die. Not always, but usually. So Cushing's triad is really bad. Now, triad means three things. Three things are happening. Triad, three. Let's do the abnormal respiratory first, because it's the easiest. They start to push on the respiratory centers in the brain, so they will have periods of apnea. So the respiratory rate, they will develop bradypnea. They will have a slow respiratory pattern with periods of apnea. The most common, not the only, but the most common respiratory pattern is Cheyne-Stokes. Cheyne-Stokes. I think I'm spelling that right. Cheyne-Stokes respirations. Typically, Cheyne-Stokes is neuro in nature. It doesn't have to be. I've seen it not neuro, but almost always it's a neuro patient. It's a neuro-driven periods of apnea. And it is shallow to deep, followed by a period of apnea. So it's so it's shallow to deep respirations followed by a period of apnea. And I get tickled almost every semester, especially if somebody goes up on 9 Tower or up to Neuro ICU, and I'll get a call in the middle of the night. And they'll say, "Are you here? Are you in the house? Are you in the house?" I'll say, "I am. Come. I want you to see something. I want you to see something." I go up there and they say, look at this breathing." I'll say, "Uh-huh." They said, "Look, it's Cheyne-Stokes. It really is. You said it. You said it. They really do." I said, "Uh-huh." I've seen them many times, but you said it, and they really have them. I said, I know. That's why I said them. That's why I said it. But they really do have them. It's really common, very, very common, and they're typically pre-herniation. And a lot of times we see these in patients that aren't going to be resuscitated, that kind of thing. People that have chosen not to go on a vent, that type of thing. So they get an abnormal respiratory pattern. They get periods of apnea. All right. Then we get some hemodynamic changes, some vascular changes. All right. So these are a little bit more difficult. All right. So cardiac output equals stroke volume times heart rate. That's the equation of life. Cardiac output equals stroke volume times heart rate, which you learned in A&P, back to A&P. But the equation of life is very important. So cardiac output, which is indicative of your blood pressure, equals stroke volume times heart rate. So one of the things that we see in the neuro patient is if we know that an increased MAP causes an increase in your cerebral perfusion pressure and their blood pressure tends to go up, okay? The body says, "Oh, no. We don't want your blood pressure high, because when your blood pressure is high, your ICP is high." So you know what? To keep your cardiac output down, which keeps your blood pressure down, we will lower your heart rate. We will lower your heart rate. So typically, you will start to see bradycardia. And the bradycardia is so that their cardiac output decreases, which will decrease their blood pressure. It's just like how a beta blocker works, basically. It lowers your heart rate, which lowers your blood pressure. But this is just a compensatory mechanism. And then you start to see an increased in their systolic blood pressure with a widened pulse pressure. Now, widened pulse pressure is the difference between the systolic and the diastolic blood pressure. That's what a pulse pressure is. The difference between a systolic and a diastolic blood pressure. So this is not good. These are what we see as the person's not doing well, okay? So here's what's happening, and it's a little hard to explain, but bear with me, but this is what happens. When your ICP goes up, you will get an increase in your systolic blood pressure. They go together. Okay? When you get an increase in your systolic blood pressure, you have some special tissues in your aortic arch and in your carotids. They're called pressor receptors, or the baroreceptors is another name for them. And they respond to pressure, to blood pressure. And these special tissues say, wow, this person's blood pressure is really, really high. I think if I cause some vasodilation in their periphery, in their blood vessels, that would lower their blood pressure. And it's exactly what happens. It sends a signal down and it says, you know what, vasodilate, and we're going to lower this person's blood pressure because their blood pressure is really, really high. But it lowers, it vasodilates everywhere, including the head. When it vasodilates the head and the blood vessels in the head gets bigger, more blood is in the head. Therefore, blood is taking up more room in the box. And therefore, my ICP goes up. When my ICP goes up, my systolic blood pressure goes up. That's a body's mechanism. So my systolic blood pressure rises again. The pressor receptors say, oh, wait a minute, the blood pressure went up. I need to vasodilate some more. When you vasodilate, you decrease your systemic vascular resistance. Jane will talk more about that in cardiac. But when you decrease the resistance coming out of your left ventricle, it decreases your diastolic blood pressure, okay? So when you increase your blood pressure, your systolic goes up. When you vasodilate, your diastolic goes down. So my pulse pressure is widening, but the pressors say, oh man, that systolic blood pressure is high. Vasodilate some more. So it does it. When it vasodilates all over your body, drops your diastolic blood pressure, it vasodilates in your head, which makes more blood go to your head, which increases your ICP, makes your ICP worse, which increases your systolic blood pressure. So again, your systolic rises more. Your pressors say, no, vasodilate. I got to drop this systolic blood pressure. When it vasodilates, your diastolic drops, puts more blood in the head, systolic continues to rise. So I'm in this negative reflex. I'm in this negative compensatory. So what's happening is this body's trying to fix itself, but it's actually killing itself. Because it's trying to lower your blood pressure by vasodilating, and it's also vasodilating the head. And that's going to increase your systolic blood pressure, which is going to increase the blood flow. It's going to increase your ICP. Bad news, bad news. So that's why you get a widened pulse pressure. That vasodilatation, trying to drop your systolic, is lowering your diastolic. But when it vasodilates your head and you increase your ICP, it increases your systolic blood pressure. Okay, it's just how it works. All right, so it's pre-herniation. So what's herniation? It's when you squish your brain outside the box. You don't really have to know the different types of herniation. I don't think it's up to you to know these. There's one you do know, though. There is one you know. And you're saying, I don't know any of them. Well, yeah, you do. You just don't know the name of it. The most common kind is the cingulate. You don't know this one, but it is the most common. And it's about the only one that won't kill you. Cingulate, you've got 4 ventricles inside your brain. You got 4 little hollow cavities inside your brain. Cingulate is when one of those hollow cavities or more of them collapse. And so it just makes more room inside the brain. And we see this sometimes with hypertensive patients. They don't even know it collapsed. And it just makes more room in there. And typically, if they have an autopsy later in their life for some other reason, they'll find out that they had a cingulate herniation. And it really doesn't affect their life. These people live all the time with cingulate herniations. So those kind you don't even really see. The one you may know is an uncle herniation. And you're like, I don't know an uncle herniation. Yes, you do. Uncle herniation is the one that came out through the opening of your orbit. And when it squishes out through the opening of your orbit, it compresses on your optic nerve, and it is the one that makes one pupil dilate and one pupil stay small. The unequal pupils, a fixed and dilated pupil and one that's not. That's an uncle herniation. You didn't know it was called an uncle herniation, but that's the one that it is. So this is very late. You don't see that fixed and dilated unequal pupil until they're dying. They're pretty much dead. The central one and the cerebellar is, well, the central and the cerebellar are going to be the ones that come out of major holes, especially the cerebellar. It's the one that comes out where your spinal column, your foramen magnum, and you have instant death. Both of these were going to affect your midbrain, and they're going to knock off your respiratory centers. And these people typically die immediately. So herniations are really not good. The cingulate is probably okay. The other three are not good. So we want to catch them before they get to that point. Okay. So we would like to catch them in the early signs of increased intracranial pressure and not the late signs. Now, there is some very important things called posturing. Posturing is how patients present when they have pressure, increased intracranial pressure in their brain. Now, there's two kinds of posturing. There is decorticate posturing and there is decerebrate posturing. And a lot of people just call it posturing because they can't remember which one is which. But for NCLEX purposes, you have to know, and for Janie purposes, you do have to know the difference between decorticate and decerebrate. Now, first of all, these are involuntary. These patients are unresponsive. You don't have posturing unless the patient is unresponsive. Right? And so the cortex, okay, the cortex of the brain, you get a disruption with the decorticate. And when you have the decorticate, you will have when you stimulate the patient, like suctioning, sometimes turning, sometimes even talking to them, but usually not. Stimulating is the most common one that I think. Some people will hurt the patient to stimulate them. I don't believe in hurting the patient. So it could be that you just shake them. Some people will do mean things like sternal rubs and stick their finger out really big. I mean, I think it's okay to put your hand on their chest and rub them, but I don't think you need to take your knuckle and dig as deep as you need to. But I think putting your hand on their chest and pushing hard and rubbing is fine. But I don't think you need to leave bruises on a patient in order to stimulate them. And you will see people do it. You'll see nipple twists. You'll see trapezius squeezes. I just think you need to stimulate them hard, but you don't need to hurt them. I don't believe you need to hurt a patient in order to get a, just, if you pay attention to what they do when you suction them, that's about as deep a stimulation as you can give a patient, is to suction them. So pay attention to what they do. Decorticate, you will get an internal rotation of their arms and their wrists and their fingers. And so I'm going to pull this down so I can show you. When you stimulate them, their arms will turn in like this. Okay. So they'll be kind of in the bed like this, and you stimulate them, and they'll have an internal rotation toward the spinal cord, decorticate, in toward the core of the body. I can dip my feet. It's hard. This is what I do need to be in person. Okay, Janie, come on. Their feet will turn. I can't do it. Their feet will Can't do it. Their feet will turn in. Well, they'll go pigeon-toed on you. Okay, their feet will turn in also. So when you go, their hands will turn like this, and their feet will turn in like this. I can't get it down where my feet are, and their feet will turn in. Okay. Decerebrate is not the cortex. The decerebrate is deeper. The pressure is pushing in deeper toward the midbrain or the brain stem, and they will pronate. So instead of this, they will turn their wrists like this. Now the toes stay turned like this, but they will point downward. Instead of like in like this, they'll point downward. They still turn inward. They don't point like this. They still turn inward, but they will go like pointing down, like a ballerina would point down, sort of. Instead of more across each, they don't have to cross, but they'll like point down. More extension. Okay, but they pronate. They turn in and they pronate down. The other ones turn in like this. The other ones turn out like this. Okay, now you don't have to do it together because you know that there's a midline. So if all your pressure, and it is contralateral, that means it's on the opposite side. So if your injury is in your right hemisphere, but you don't have any increased intracranial pressure on the left, and you stimulate them, the right side may just be fine. The right side may be fine. And so they may do this. They may do this. And then let's say 2 hours later, 3 hours later, you suction or do something, and all of a sudden you note that they're doing this. Well, now you know that the pressure is on both sides. It's crossed the midline. There's more diffuse pressure. There's more diffuse pressure all over their head. And let's just say they've been doing this, and now all of a sudden you're seeing this. Well, then you know that on the right side, it's deeper. It's more in toward the midbrain. That would be a worsening of their posturing. It's getting deeper, away from the cortex and in toward the midbrain. So it doesn't have to be equal. You want to pay attention to what kind of involuntary movement they're having and where's it going? What does that indicate?
Miss Janie?
Yes.
Is it when you talked about it being contralateral, is that for either type of posturing?
Yes. It's all contralateral. It changes sides at the midbrain. Yes. Now your pupillary response is ipsilateral. Pupils respond on the same side as the injury. That is above the crossover point. So pupils are ipsilateral. If you've got one pupil that is sluggish and one that's not, it's on the same side as the injury. Pupils are ipsilateral. Extremities, whether it's movement, whether it's posturing, whether it's hemophoresis, whether it's sensation, down extremities are contralateral.
Janie, I have a question.
Sure.
Is this the same thing as neurostorming, or are these two different things?
Well, neurostorming is when you're having you're not dealing with the stimulation. So maybe and they're having this huge amount of output from their neurological synapses. They're firing. It's almost like, it's not a seizure, but it's almost like just a rapid output of sensations, and it's not necessarily good when they neurostorm. So we don't want them. So we will typically sedate them or put them in a low stimulation environment. It's not seizing, but it's almost like seizing. It's just different than seizing.
Okay.
We don't really want them because it can increase their temperature.
Mm-hmm.
It can cause them to have abnormal vital signs and cause some tissue damage into their brain, that kind of thing. So we don't recommend neurostorming at all. But it is a way of them just demonstrating that their brain tissue is very irritable. Okay. And so we don't like that. It just shows that they have some irritable tissue and they're just having sort of a repetitive output from injured tissue. I guess is the best way. And so they might show it some with their posturing if that's what they're doing, but they can show it with just they turn red, their vital signs will get out of whack, they'll become very hypertensive, their ICP will go up, things we don't want to happen. It doesn't have to be just posturing, but it could be posturing. They're just showing irritability in their neurological system. Okay. So those are all signs. That's what posturing is. All right, you all, it is 10:12. I will see you all back here. Let's just say it at 10:20, okay? And so take a good 8 minutes for me and then come on back and I'll try so I can try to get finished as close to time as I need to be. All right. I'll see you all back at 10:20 and we'll try to finish up here. All right. It's here. Whew. Check the roll. What did I miss? Cleveland, Cannon, Milligan, Neff. Freeman. on here. Henry. Parker, McKenna, Steph, Kelly, McKenna. Didn't mean to do that. Oh, is that her? This is so hard to check this. Maybe if I make it big. Can't park in here. No, it's not too. Carissa Kelly, is that what I'm looking for? Yep. Kelly. Neff and Rep.
Did you say Kelly?
Yeah, I saw you. I found you.
Okay.
Sorry, I didn't realize that. I'm looking for Neff and Rap. Are you all here? Oh, there's Neff. I see Rap. I see Rap. Just a minute. There's Rap. Neff. They might be on break. They may be off. I'm just looking for their names. I don't think Neff's on here. I don't think Neff is on there. Okay. All right. At least we got it working. I don't know what the problem was this morning. I think because it was working great, and then all of a sudden, boom, everything disappeared. I think it was a Zoom issue. Because God knows we're not going to take responsibility. Going to get my lashes done after we're done here. Get my eyelashes put back on. I like to have my eyelashes. I'll be beautiful next time you see me. I don't know. Might be off by the time y'all see me. When do y'all see me again?
Does it feel weird when you get your lashes put on?
I don't even feel them. I've
Really?
been wearing them a long time though. But
I
I
always feel
Go
like
ahead.
there's something in my eye.
no.
But I love the way they look.
I do the individual ones.
Oh,
They cost a lot of money, but I'm going somewhere different today because, well, I like the one that the lady that's been doing mine I like, but I don't like what she does. She takes forever, first of all. It takes her like 2 to 3 hours, which I don't
Oh my
have 2 to
God.
3 hours to fool with her. And then she'll like turn around and watch TV for like 20 minutes. She'll be gone for 20 minutes. And then she'll come back, and then I'm like, I got better things to do than for you to watch
Can
TV.
you just do my eyelashes, please?
And then she'll, I don't know, she just drives me crazy. Okay. All right. When am I back? I'm not back until next Wednesday. Okay. Oh, good. Okay. All right. So when we're talking about increased ICP, there's lots of ways to diagnose this. Typically, we do a CT scan. You can see the tissue is swollen. You can see increased ICP on a CT scan. It is the most common. You can use an MRI. You can use a PET scan. It is the most common. We don't typically use a lumbar puncture because we worry about the pressure being in the brain. if you do a lumbar puncture, it can cause it to herniate, kind of like siphoning gas. Once you get the flow flowing out, tissue can follow with it. But we are able to measure ICP with a lumbar puncture. But if we suspect that they're having an ICP problem, we don't say, well, let's do a lumbar puncture and see what their pressure is. That's not the purpose of a lumbar puncture, even though we can measure ICPs with a lumbar puncture. It's not the same as putting it in the brain, but we are able to see if their pressures are a little high. But we typically can just diagnose it with a CT scan. So when we're talking about it, the common nursing diagnosis is altered tissue perfusion, cerebral, either because of not enough blood flow or too much blood flow, one or the other. Our goal is that they will have an ICP between, some books say 5 to 15, some books say 0 to 15. We're not really worried as much about the low ICP as we are the high ICP. We want them to have a patent airway, because a decreased level of consciousness, we know we have trouble maintaining our airway, and airway is always our highest priority, always, always, always. And we also want a normal fluid balance, because that's going to affect what's in the box is our fluid balance. And so all of those have to do with our cerebral perfusion. We also are worried about our respiratory status. A lot of patients with increased ICP require intubation because they cannot maintain their airway. Their decreased level of consciousness means they're going to have trouble and they're going to require intubation. We will electively paralyze them and intubate them. We will hyperventilate them. Why? Because PCO2 is a vasodilator. And when we vasodilate the vessels in the head, it takes up room in the box. So we will vasodilate them. We will hyperventilate them. When I was an ICU nurse a lot of years ago, we would hyperventilate them a lot. I mean, we would set their rate at probably 36, 38. Now we don't hyperventilate them quite as much. Just evidence-based practice has said don't do it quite as much. We probably set them at about a 28 rate, maybe. We still are going to hyperventilate them, but not quite as high as we used to. And that's what evidence-based practice is. We keep looking at what's best and what's best. So we will hyperventilate them, but not quite as much. Blood flows out of the brain by gravity. So we want to keep the head of the bed up about 30 degrees. For that, we want to not increase intrathoracic and intra-abdominal pressures. So we want to use minimum suctioning. We don't want these patients to cough, because that will increase our intrathoracic pressures, which will increase our intracranial pressure. So we do minimal suctioning. However, we can't let airway is still our highest priority. So if they have a lot of secretions and they need to be suctioned, we will obtain an order for viscous lidocaine, a thick lidocaine solution. It's not a jelly, it's a solution. You can put it down the ET tube and it will numb the bronchial tree so that when you go down to suction, it does not stimulate a cough. And you can suction them out without stimulating a cough. And when they don't cough, you won't increase their ICP. So if they're coughing a lot with suctioning or they're having problems with that, we can do it that way. We want to keep their blood pressure down, because an increased blood pressure causes them to go into possibly a Cushing's triad. So we want to keep their blood pressure down. We want their systolic to be enough, so at least 100, and we will typically keep them between 100 and 160. You may say 160, that's really, really high. Well, it is high for some people, but for some people, it is not. Remember that people that may have been running a high blood pressure to start out with, their vessels have been sort of outstretched for a while. And so let's say they've been running in the 200s or the 230 ranges, 230 over 140 or 120 for 10 years. If you take them down to 120 over 80 or 110 over something, when their blood vessels that are kind of big, think of a balloon that's been blown up and you untie it and let it down, that balloon's kind of big and floppy. if you take somebody whose blood vessels have been distended for a while and you take them down, they're going to have big floppy blood vessels. And so that 120 or 110 blood vessels are going to collapse upon themselves, even though at most people at 120, they'd have nice little patent blood vessels, but those big floppy ones are kind of going to be crinkly and they're going to kind of waver upon themselves. So we may have to keep them at 160 because they're used to being out like this. And when you lower them to this, they get really crinkly, for lack of better words. So somebody who came in at really, really hypertensive, we're not going to lower them down to probably any less than 160 because it'll just clog off. And when they clog off, I have no blood flow going through them. So you have to look at each patient individually. We might have to electively paralyze them if they're really, really agitated. And we find that when they're agitated or when they're coughing tremendously or fighting the ventilator, it's causing an increase in their ICP. We try not to put them on benzodiazepines because it really, really messes up the neuro assessments on the patients. So we try to avoid our benzodiazepines, which are your pamelamas, your diazepams, your lorazepams, your alprazolam, all your pamelamas. They really tend to mess up with these patients a lot. So we avoid most of the benzodiazepines with them. Positioning is important. Again, head bed up 30 degrees because blood flows out of the head by gravity through your external carotids. And we keep the head in alignment because if they're leaning there and they've got their head kinked off, then it's not going to flow out of this side. And I'm already decreasing blood flow out of my head if I kink off my external carotid over here. So we want to keep the head a bit up 30 degrees and keep their head in alignment. You can put towel rolls. You can take an IV bag and put it in a pillowcase and put 2 IV bags on the side of their head. You can put sandbags on the side of their head. If you need to, you can take one of those soft collars, like ones that people have had surgery and put a soft collar around their neck. Just make sure you're not occluding their external carotids, but you want to keep their head in alignment, especially if they have like a decreased LOC and they're not able to kind of hold their head up very well. But you want to keep their head in alignment. A lot of people do not close their eyes all the way. And so especially if they're unconscious, you want to make sure that you close their eyes or take their eyes closed, especially if their eyes are not closed all the way. They often will have moisture like liquid tears to put in their eyes or ointment. Many patients that have had head traumas or problems, they come out of that and they have to have corneal transplants because nobody kept their eyes moist. So you always want to keep their corneas and their eyes moist so that their eyes, when they do wake up, are functioning. You can't let the corneas dry out or they've lost their corneas. We want to avoiding Valsalva. We don't want them to get constipated, so they should be on stool softeners. You do not put anything up their butt. When a rectal stimulation causes an increase in ICP, so they should not be getting enemas or rectal stimulations. But so we want to not have them get constipated that will also stimulate the rectal opening. So stool softeners, make sure that you're doing stool counts and watching that they're having bowel movements and what we can do to make sure that they don't get constipated. Because we don't want them valsalving. It can increase their ICP. We're going to do the neuro assessment often, probably at least Q1 at first. In the ER, we do it Q15 minutes when you come in because we're really looking for immediate changes. And we can use lots of different methods. The most common by far is a Glasgow Coma Score on anybody with a head type of situation. We use the Glasgow Coma Score. It standardizes a neuro assessment. Most of you have done Glasgow Coma Scores. I'm not going to have you, you don't have to know the numbers for this, but you do have to know what it means. Okay. So most of you say, well, I know what it means, but I bet you really don't know what it means, but you think you know what it means. So it's best eye-opening. If you go into a patient's room and their eyes are open, when you go in the room, then they get a 4. If you have to go in the room and their eyes are closed and you go, Janie, and I open my eyes, it's a 3. Okay. If you say my name and I don't open my eyes, but you go in and you touch my shoulder, you say, Janie, and I open my eyes, it's a 2. Pain does not have to mean pain. Pain means you had to touch them to get them to do what you wanted to do. It doesn't mean you have to cause them pain. Maybe a touch does it. Maybe you had to. I mean, I guarantee you, in class, I usually walk up to somebody and I grab both their shoulders and I sort of shake their shoulders. And I said, if you're going to wake up, this will wake you up. I do not have to twist your nipple to wake you up. If you're going to wake up, you will wake up. And then none is none. It's a 1. If you don't open your eyes at all. Best verbal response. Janie, what day is this? This is Tuesday. What month is this? This is January. I get a 5. Janie, what day is this? This is Wednesday. What month is this? This is January. I get a 4. Today is not Wednesday. Today is Tuesday. Okay, I get a 4. Janie, what day is this? Sally, come in here, Sally. Sally, come in here. I get a 3. In order to get it confused, you have to answer the question and get the answer wrong. If you do not answer the question, you answer something, did you see that mouse? There was a mouse that went across that ceiling right there. There was a mouse. Did you see the mouse? That is inappropriate. That is not confused. Confused is only to answer the question and get the answer wrong. Inappropriate, you gave a response that had nothing to do with the question that you were asked. I bet you did this wrong. Incomprehensible. Janie, what day is it? And none is none. Best motor, obeys commands. Purposeful, you stick me and I pull my arm back. You put an NG tube down, you're like, I'm doing this. That's purposeful movement. Withdraws is not jerking your hand back from pain. Withdraws is like moving away in a fetal type of a position. Flexion and extension is posturing. Flexion is decorticate, extension is decerebrate. And none is none. 3 is the minimum, 15 is the maximum. Somebody with a trach or a ventilator that is not speaking, even if you say, are you Janie McCluskey? Is this your son? I still get a 1. I cannot talk. It's a 1. I have to be able to talk. I have to be able to answer under best verbal. Now you can define it. You can say why I only got a 1 because I'm intubated. Or, if I have a point board, it's still a 1. Okay. We accept 13, 14s, and 15s as normal. 8 and less, or less than 8, or right around 8 or less, the patient is in a coma. So when I'm in the ER and medic calls into me and says, we got a Glasgow coma of 8, I know I'm expecting a comatose patient. If they tell me they're bringing in a 13, I know they might be a little confused, but they're probably okay. They just had a wreck and they don't know today's Wednesday, or they're drunk but they don't know today's Wednesday. All right, I can live with that. Most of you all don't know what the day of the week is either. And I know I damn well don't know what the day of the week is. I'm old. Okay. So that's the way you do a Glasgow coma score. All right. So how do we treat increased intracranial pressure? The drug of choice is an osmotic diuretic. Yeah, we put the head of the bed up 30 degrees. We keep the head in midline. We prevent valsalving. We don't let them cough. We don't teach coughing. All those, we prevent it. But if they really have it, then we've got to get their ICP down. We get it down with a osmotic diuretic. And the osmotic diuretic of choice is mannitol. It is very, very hypertonic. Therefore, it sucks fluid to it. It sucks out the cerebral edema, puts it back in the circulating volume, and you pee it out. Now, mannitol is got crystals in it, and I don't know how well you all can see the bottom. Here, I'm going to turn this upside down and got the liquid out. Can you see this stuff in the bottom of this? Those are the crystals. This is mannitol. Those are the crystals that is in this solution at room temperature. This is the crystals that are in this solution. All you got to do is run this under warm water and those crystals will dissolve, and then just shake it up, and then it will be just a clear solution. However, there are still crystals in here that maybe are not completely dissolved that you can't see. Anything that has crystals in it must be given through a filter, an inline filter, just like the filter that's in hyperalimentation or TPN. Now there it's given for a bubble catcher, but in this case it's a crystal catcher. If we give mannitol IV push, then I have to use a filter needle. So if I drew this up with a filter needle, I would draw it up with a filter needle. I would take the filter needle off, dispose of it, put a new filter needle on it, give it IV push back to the patient through a new filter needle. I wouldn't give it through the same filter needle. All those crystals I just collected, I injected straight back into my patient. Now, I know with the new systems, you wouldn't have the new filter needle. You probably have to give it directly into one of those blue ports because we don't really have injection ports. But if you don't have that, it's best to give it back through another filter needle. So you got to look at what kind of system you have. But you would definitely draw it up through a filter needle to try to catch any of these crystals. And Jane's going to talk about Dilantin this afternoon. And Dilantin has crystals. Now, you don't see them as much as you do in mannitol. But once you dissolve this, or once you sit this bottle in warm water, these crystals will go away. Okay. And then we're going to watch their ICP. It's a very potent drug. And so their ICP, we can watch it if they have a monitor in. If they don't, we got to watch their blood pressure because it is a diuretic and it can make them drop their blood pressure. It'll start working in about 15 to 30 minutes. But it is the diuretic of choice to lower somebody's ICP. It's very, very potent. We can also use other diuretics like a loop diuretic, furosemide being the most common, like Lasix, or we can use bumetanide, which is Bumex. Okay, and of course it's a loop diuretic. It's a potassium wasting diuretic, and just like always, you would need to know their blood pressure before you gave it. You would need to know their potassium level before you gave it, just like you were giving it for congestive heart failure. It's still a potassium wasting diuretic. We typically use a corticosteroid because what does that do? It decreases edema. Steroids decrease edema. That's one of the functions. It's not the only function, but it's one of the functions. It decreases edema. We typically use dexamethasone. That's called Decadron. It is the typical steroid used for cerebral edema, right? And just like any steroid, you can have side effects. It can cause fluid volume excess. So we got to watch our dose on that. It's typically not a real strong dose because we don't want fluid volume excess, but we do want the edema to go down. It can cause hyperglycemia. You know that. It can decrease the immune response. So we got to watch for infection afterwards. You know that. It can cause moon face, buffalo hump. You can have any of them. Changes in personality, osteoporosis, if it's long term. Probably these won't be long term. But any of the signs of steroid use. You should have already learned about steroids up to now. They might be on an anticonvulsant Phenytoin, which is Dilantin, would be the drug of choice. And Jane will talk about those and seizure precautions this afternoon. So I'm not going to go over those. We might need to sedate them. We typically use barbiturates like phenobarb or secabarb. Those are probably the most common. This really slows down their metabolic rate, so their head isn't having those thyroid storms. Listen to me. They're neurostorms. But it does skew the neuro assessment. I won't be able to assess their neurological status. I won't see that change in the level of consciousness if I sedate the patient. Very quickly, because it's barely into what a beginning practitioner is expected to know, is about the ICP monitoring. Again, it's used to guide practice. And it's put either in the ventricles, in the subarachnoid spaces, or in the brain tissue itself. And which one is used depends on what they need and what the doctor wants to put in. There's probably 6 of one, half dozen of another. The only thing that's different is that in the fiber optics, you can't pull off cerebral spinal fluid. In the other ones, you can. So one simply gives you numbers. The other ones give you numbers and will allow you to also pull off some cerebral spinal fluid type of thing. So which ones you use is depending on what is needed most for the patient more than anything. And so when we're talking about these, they simply put a little tiny hole through the skull, very, very, very thin, very, very small, with a drill. Just a tip. Some people use a hand drill. Some people use a little zip drill, just whatever they use in your hospital. And then they will, with a little stylet, they'll put a little catheter in there and then pull the stylet out, and then they hook that to the monitor, all right, with a transducer to the monitor. Obviously, we don't push anything through that line. You don't give fluids or meds or anything through that line, because what would that do to the box? It would increase pressure within the box. So we don't push anything. We're simply going to either measure or pull stuff out of it. We can drain cerebral spinal fluid, which would make room in the box. So that would be kind of nice. So we don't flush it. We don't put anything in it. The biggest problem with the monitor is infection. What did we do? We opened up a hole into the patient's brain. So we opened up a risk for infection. 1 to 22% of the people that get a ventricular monitor will get a brain infection, no matter how sterile it's put in. So we do worry about brain infections. That's why, unless you really need it, we don't do it. But sterility and taking care of this is very, very important. We typically will shave a little bit of hair around it, not a big spot, just a little spot. And we will use something called collodion around it. The best way I can describe collodion is if you've ever used Nu Skin or super glue. It's almost like super glue around it. So it's like a self-adhesing bandage looking stuff, kind of a super glue around it. So it forms sort of an occlusive bandage around it. So it's not like paper tape or anything like that, because that was not going to stick around it. But we want to form a occlusive seal around it, and it's called collodion. We almost always put them on prophylactic antibiotics because they are such at risk for a brain infection with this. So we really worry about that. So as soon as we're done, we get their ICP down, or we're done, it comes out. We don't want to keep this in any longer than is necessary, because the risk of just a brain abscess is just too high. Okay. All right, so moving on into head injuries and head trauma. Head injury and head trauma are two different things, but we really use the terms sort of interchangeably. A head injury is injury to the scalp, the skull, or the brain itself. So if you come up and hit your head on the counter and you get a laceration right here, you have a head injury. And all you needed was 3 stitches and you had a head injury. If you do that and you get knocked out, you had a change in the level of consciousness, you had a head trauma. So if you just hurt your scalp or your skull or your brain, but you didn't get knocked out or you didn't have a change in the level of consciousness, it's an injury. Once you have a change in the level of consciousness, it's a trauma. With that said, people just kind of use them interchangeably. But that's what the true definition is. Yes.
What about like a concussion? Does that
Well,
people
typically
have lost their
concussions,
concussion, or if they're just, would you say?
they typically have memory loss. They sort of don't know what happened at the time. They sort of got knocked out even for a short period of time. And then they sort of forget what happened right at the time of the incident. That's considered a head trauma.
Okay.
It's a change in the level of consciousness. Now, depending, obviously, there's different levels of head trauma, obviously. Most people with head trauma die immediately. So like in a car accident, they're dead at the scene. Most head traumas are dead at the scene. If they do live, most will die within 2 hours because they develop massive increased intracranial pressure, and most die. If not that, they will die within three weeks just from multi-system organ failure, MSOF. That's one way, or MODS, multi-organ dysfunction syndrome, depending on what book you're looking at. Multi-system organ failure, MSOF, and MODS, multi-organ dysfunction syndrome, are the same thing. Multiple organs start to fail. Some books call it MODS, some books call it MSOF. All depending on what your book is, and even with Lewis, probably depends on what chapter you're in. They call it different things. It's the same thing. If you don't die in 3 weeks, you'll probably live. Good for you. Okay. So a lot depends on how much your brain's injured and what's going on, because we know lots of people with concussions and not so major loss of consciousness live. But statistically, more will die than will live. So again, head injury can start with a simple scalp laceration. It's the most minor, but the head tends to bleed. The scalp tends to bleed tremendously. I was watching Dr. Pimple Popper this last night. I don't know if y'all watch Dr. Pimple Popper. I love Dr. Pimple Popper. And she was removing this cyst from this guy's head, a huge cyst. And, she was like, this is like the most bleeding I've seen in a long time. She said, how much bleeding from the scalp? I said, yep, scalp bleeds tremendously because there's just lots and lots of blood vessels in the face and in the scalp. Lots and lots of blood vessels. After the scalp, you get down to the skull. And typically linear skull fractures where you just have a break in the skull, not so much. But if it gets pushed in, if it's a depressed skull fracture, what does it do to your box? It makes your box smaller. Well, that means I have an increased intracranial pressure if my box gets smaller. So depressed skull fractures are worse than just a linear where you just crack your noggin. Okay? So we worry about depressed skull fractures. So they're gonna have to go in and elevate that skull fracture so that the box is in its normal amount of volume again. You can't decrease the size of your cranium because you're going to have increased intracranial pressure. Now, just like you learned in 151, the type of skull fracture is like any fractures. It'll either be simple, meaning one crack. It could be comminuted, meaning you have a bunch of little cracks. Okay, or it could be compound, meaning that it communicates with a break in the skin. We sometimes call that an open fracture, but it's actually called a compound fracture. Now, any of these could be depressed. If it's depressed, then it's bad, whether it's linear, where one side went in and one side didn't, or whether it's lots of little pieces that got squished in. Maybe it doesn't have to be squished in. Or whether it's compound and part open or squished. So depressed is worse and compound is worse. Because when it's open to the skin, you've got an opening for infection to get in. Almost any compound fracture has to be taken to the OR and be washed out. I don't care if it's on your finger. I don't care if it's in your head. I don't care if it's in your leg. If there's an opening to the skin with a fracture underneath, it's got to be washed out. It's got to be washed out well, because you can develop osteomyelitis under there. You can develop lots of problems in any open or compound fracture. Compound means opened. A lot of people think compound is comminuted, but it's not. Comminuted is the lots of different pieces. And compound means open through the skin. It doesn't have to be sticking out. It just means there's an opening in the skin that connects it. Okay, now, where it's located is where it's located. Okay, we have to worry about that. If it's in the frontal area, you're really worried about sinus involvement. And there's lots of contamination when you crack your sinuses. The sinuses are connected to your brain. So a lot of contaminants when you have sinus fractures can get in your brain. And these are the patients that will get the clear to pink tinge cerebral spinal fluid coming out of their nose. And we do not stick anything up their nose. So we just allow that to come out. You can put a little pad outside of their nose to catch it, but you never stop cerebral spinal fluid from coming out of somebody's nose. Because as long as fluid is flowing out, bugs have difficulty swimming upstream. So you let the cerebral spinal fluid come out, but you do not plug the nose up. Now, they may plug something up in surgery where they've tried to set the fracture, but when patients in your nursing care, you do not plug the nose. Okay. And that's called rhinorrhea. Now, a basilar skull fracture would be, of course, at the base of the brain, and the dura tears, and you will get what's called battle signs, and you'll get these big bruising right behind. Can you see my head there? You get this big bruising right behind their ears right here. These are also the ones, when you look in their ears at their tympanic membrane, the tympanic membrane, instead of being gray and shiny, will be very dusky looking. If their tympanic membrane bursts, they will have blood come out of their ear. If their tympanic membranes do not burst, you will not see blood in their ears because it's behind the tympanic membrane. But if it bursts, then they'll have blood coming out of their ears under a basilar skull fracture. Then you've got the orbits. You've got the crack in the bones behind the eyes. And these are the ones that get the huge bruising. Can you see those?
Raccoon.
Raccoon eyes. This is my mother, who's dead. She's not dead here. And she fell and she had orbital fractures. She had a bunch of fractures, but those are raccoon eyes. Okay. But I said, Mom, I got to take your picture. I got to take your raccoon eyes. I got to show my students your raccoon eyes. So you go, oh, take my picture. So she didn't care. But you got to remember that sinuses or your eyes are all connected to your brain. So we don't put anything up your nose, because how do I know when I go here, if you have a fracture, how do I know that it's going to make that turn and go down and not go here and go straight into your brain? If someone has a frontal fracture, orbital fracture, sinus fractures, or facial fractures, nothing up the patient's nose. So if they need an NG tube, we sit it in their mouth and send it down into their stomach, not in their nose. We may still call it a nasogastric tube, but it doesn't go in their nose. It's an oral gastric tube. We still say, put an NG tube down, but put it down their mouth. Put an oral gastric tube down. I've already talked about this one. So minor head trauma. The minor is a concussion. It's the most minor. They get their bell rung. They might have a headache. They'll have retrograde amnesia, which means they don't remember the event. They might have it up to 6 weeks where they're like, what happened to me? And you're like, I told you, you were on a wreck on Independence. Well, what car? The red one. What happened? You were in a wreck on Independence. What car? A red one. And then for 6 weeks, they ask you the same question over and over and over. And you're like, oh my God, this person is an idiot. They're not. They have concussive syndrome. And it gets more and more and more spread out. But at first they're asking you about every second. You're like, I'm not answering again. You're doing this on purpose. They're not doing it on purpose. It's very, very common. Typically, these patients are sent home with instructions on what to do, what to come back to the hospital for. And I've got some examples in just a minute what to come back for. So that's just concussion. They've got their bell rung. Contusion, of course, a contusion is a bruise. The capillary bed is disrupted and they've got a bruise in the brain tissue themselves. They typically have a change in the level of consciousness. It makes sense. The smaller the bruise, the less brain tissue that's damaged. The larger the bruise, the more brain tissue that's damaged. We usually worry a lot more about this because where the capillary bed is disrupted, there's not blood flow going through there. And so we have to worry about that. And the blood that came out can increase your intracranial pressure. So we worry about large contusions, and we watch these people in the hospital. We do not send contusions home. We're going to watch them until they start to reabsorb. A laceration, the brain itself is cut. Bad, 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 bad. Often they die. Bad hemorrhage, bad increased ICP. When there's a cut, I don't know if you've ever touched brain tissue, but it would be like you can't sew it up. It's like sewing Jell-O. Brains feel like Jell-O, and you can't sew them up. You couldn't put stitches in a Jell-O. So you can't stop the bleeding that's going on in brain tissue itself very well.
Question, when you say laceration, I think sometimes I would think of the skin, but if you're talking about it in a test, are we just gonna assume that it's like laceration of the brain, or y'all gonna specify? Just curious.
Yeah, if I said scalp, it would be the skin.
Right, yeah, okay. I just want to make sure.
Okay, and then you got the hemorrhage, different type of hemorrhages that are taking place in the brain. The epidural hemorrhage is in the epidural space. We usually think of these as arterial. They can be venous, but it'd be a big vein. But usually they're arterial, which means they are bleeding fast. Most of these people die at the scene. But if you've ever seen an ER nurse with a patient on a stretcher running down the hall, truly running, it was probably from an epidural bleed. Okay. These patients are developing very quickly increased ICP. They typically, for medical find them unconscious. They wake up in the truck and they go, tell my kids and my husband I love them. Then they go unresponsive again, and they will typically die. They have loss of consciousness followed by this time of fluidity, brief lucidness, and then they go unresponsive again. They have a severe headache, and they will usually have vomiting not associated with nausea, and then they're unresponsive and they die. They die very, very quickly. Most do not make it to the hospital. An epidural bleed dies very quickly, quite often from trauma, but not always. They can blow a big artery, but not often. A lot of these are kids that, these are, well, not this, but epidurals are bad bleeds. Most do not make it to surgery. Most do not live. Now, subdural bleeds are usually venous, and they bleed very slowly. It can take hours to weeks to develop. We have time to get them to the OR. We have time to take care of this. Okay. They can maybe just drill some boreholes in them, put a drain in there, and actually put what's called an EVD, an external ventricular drain. When we have students go to their preceptorship up on 9 Tower, which is the neuro just floor, I'd say in that night, when let's say you have 5 patients assigned to you, I'd say 3 of your patients will have EVDs in up on neuro. These patients will just have this external drain in there. These can be missed because it can, if you have a high risk group, like a patient with Alzheimer's, because that change in level of consciousness got missed because they're always confused, or maybe an alcoholic who maybe has periods of being unresponsive from alcohol abuse. And then all of a sudden they usually wake up, but now it's been 4 or 6 hours and they didn't wake up, or that type of thing. You can actually miss this quite often. So these are very slow bleeds, but they can usually be treated very, very well. We can usually evacuate that subdural bleed and they will be fine. Typically, very slow bleed is a subdural bleed. Then we have intracerebral hemorrhages. Now, this is a bleed that is within the brain itself. So this could be like the example of that laceration would be an intracerebral hemorrhage, for example. But there are other kinds than that. Okay, doesn't have to be that. This could be somebody that like blows an artery from hypertension. It could be trauma, like a car accident. It could be a gunshot wound to the head or a stab wound to the head. It could be somebody that we've given TPA for a heart attack. And we say one of the side effects is major bleeding. So we might see a cerebral hemorrhage after giving them TPA. But the most common cause is a ruptured aneurysm. It can be lots of causes, but the most common cause is a ruptured aneurysm. Most people do not know that they have an aneurysm in their brain. There is no warning sign. And of course, an aneurysm is a weakening in the wall of the blood vessel in anywhere, but it's typically in the brain, but you can have an aneurysm in your leg. I mean, you can have an aneurysm anywhere. But they have no warning signs. So it's not like, oh, if they just gone and had their checkup last week, we wouldn't have seen this. No way of knowing this. This is your cerebral hemorrhage, typically. When we talk about occlusive strokes and we talk about hemorrhagic strokes, this is typically your cerebral hemorrhage, your hemorrhagic stroke patient. This patient typically has a sudden onset of a severe headache. Oh my God, my head, oh my God. Passes out and dies. They might vomit. They might have sudden loss of weakness, might have slurred speech, but typically severe headache, loss of consciousness, and dies. Very, very, very poor prognosis. In 151, you learned an occlusive stroke. Occlusive strokes do not have a headache. Occlusive strokes kind of wake up and their mouth is sort of droopy and they sort of have a slurred speech and it just doesn't seem like their left arm's moving as well as their arm used to move. Occlusive strokes do not pass out. Occlusive strokes do not have a headache. They lose function. Hemorrhagic strokes, sudden onset of acute headache, loss of consciousness, and most will die. If they do live, they will typically present like an occlusive stroke. Whatever didn't get blood flow, in other words, the vessel ruptured, so whatever brain tissue that's on down the pike didn't get its blood flow, will result in that arm not moving or that leg not moving. Whatever gets furnished blood from that blood vessel isn't working right. And so they'll typically present like an occlusive stroke if they live. But most will not live. Now, the most common kind of aneurysm. All right, so we have intracerebral hemorrhages. The most common, not the only, the most common kind of intracerebral hemorrhage is an aneurysm, a ruptured aneurysm. And the most common kind of ruptured aneurysm is a subarachnoid hemorrhage. There are others, but the most common is a subarachnoid hemorrhage. Now, again, most people that have a subarachnoid hemorrhage, which is an aneurysm, will die. But those that live will, the best way I can word this is think about blowing a bubble with bubble gum. Your bubble, it gets thinner, 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 a hole pops in the bubble gum, and then the hole sort of comes back and seals itself off. Well, that's what can happen with some aneurysms, some arachnoid bleeds. They'll blow, and then they'll sort of come back on themselves and form the wall back again. If we can keep them alive evidence-based practices said if we will wait about 2 weeks before we take them to the operating room, they have a better chance of survival than taking them right now. Once they blow, let's try to keep them alive for 2 weeks because they will do better than to take them immediately to the operating room. So what do we do to keep them alive? We've got to keep their ICP down. So we sedate them. We put them in a chemically induced coma. We don't paralyze them, but we sedate them. We put them into a room by themselves in the ICU. We turn the lights down. We pull the blinds closed. We try to keep the monitor at the low. We don't turn the alarms off, but we keep it very low. We tell the family, we don't want you sleeping in the room. We're going to let you go in and see them because we know you're worried. But this is not the one where we want the tape of Johnny saying, hey, Peppa, today I went to the ballpark and I did this. No one's going to talk to Peppa. We want minimal stimulation to Peppa. Now, Peppa was coming out of a coma from a car accident. Yeah, let Johnny come and talk on the video to Peppa, but not for coming out of a subarachnoid hemorrhage. We want minimal stimulations. We don't want to increase their ICP. They're going to be on stool softeners. They're going to be probably lidocaine down. So if they're intubated, we're going to suction them minimally. We don't want to increase the ICP. We do not want them to rebleed. And in about 2 weeks, we're going to take them back to the OR. And I'm going to have to do a little pencil here. We're almost done. I know I'm over. Y'all promised me you'd give me a couple minutes. And we're going to take them back to the OR. Okay. And they will do either a wrapping, a clipping, or a coiling to fix this aneurysm. So the first choice is a coiling. Why? It's the most non-invasive. And it's all depending on where it's located. They can go up like through the brachial artery. They might go up through the subclavian. They might go up through the groin. It's all depending on where it is. And they will go up to the aneurysm and they will run almost like a cardiac cath, but they're going up into your brain. Okay. And they will get to the aneurysm and they will insert this stuff that like coils up in there. And then it hardens. And when it hardens, it makes that wall solid again where the weakening is. That's the coiling, and that is the preferred method. But if it's an area they can't get to that way, then they're going to have to do a craniotomy and open you up. If they do it, they can do what's called a clipping, which is probably the next preferred. And gentlemen, I don't know if you'll know what this is or not, but most of the women will. A barrette, you know what a barrette is for your hair? Like you pull it back and you put a clip in your hair like a barrette to hold a ponytail. So they take this MRI compatible metal clip, so you can have an MRI, and they will put the clip right here. And that clip will and this just sort of sinks and sort of goes down. And this will now that clip will form a solid wall again of the vessel. Okay. And if that doesn't work, they'll take some grafting type of material, something that most people don't reject, and they will go in and they will simply, like an ACE bandage looking thing, and they will just simply start to wrap this wall. And when they get to this, it will pull this in and they will simply wrap it. And when they wrap it, it sort of forms a nice solid wall. So that would be a wrapping, a clipping, and a coiling. Which one? Where is it? What works? What do they need? How big is it? There's lots of things. Diagnosed with how the patient presented, sudden onset, short headache, loss of consciousness. CT will show bleeding. They can squirt dye up and watch where it goes, but they don't like that because dye is so hypertonic that it's going to pull fluid to it. And if I have a lot of dye that goes out the hole, it's going to pull fluid to it and increase the fluid in my box. So we have to watch our arteriograms. We don't do arteriograms on heads a lot. Certain situations, yes, but not usually for hemorrhages a lot. We typically just see the blood on CT scan. And the last slide, and I appreciate the time, is rehab is just almost like a stroke. Because if they live, they're going to have basically the same kind of situation that occlusive strokes would have. If they live. I'm done, and I apologize for Zoom, but thank you all for your patience. I do appreciate it. I didn't want to cut you all short, all right, because of Zoom.
Thank you, Janie. I had a quick question for you. When you were talking about keeping the stimulation to a minimum, and I might have missed you explaining this. I had some kids who were fighting. I had to leave for a minute. What does the stimulation do that, I know it does increase intracranial pressure. I have a brother who had a traumatic brain injury 10 plus years ago. And I remember we couldn't even whisper in his room, it was one at a time in his room, and you had to just be complete silence until they brought that pressure down. But how does the stimulation actually increase that pressure?
Well, I think you can do it many ways. I think one is it just causes an increase in blood pressure by just the recognition. And when it increases the blood pressure, it's going to increase your ICP.
Okay.
And just the fact that they hear you can cause them to maybe want to move, but they can't. I don't know the exact mechanism. I just think it probably increases epinephrine, which probably increases heart rate. I just think it's all a fight or flight kind just from the stimulation more than anything.
Okay.
There's probably more to it than that, but that is what pretty much comes to my mind. It's probably just the sympathetic nervous stimulation more than anything.
Okay, thanks. I was just curious since I'd experienced that as well. So
yeah,
thanks.
I would say that's probably it. It's probably just the sympathetic nervous stimulation that would take place and just speeds up everything.
Okay, that makes sense. Thank you.
Mm-hmm. Any other questions?
I have a question,
Sure.
Out of curiosity. So can ICP lead to a brain shift? Because I know brain shifts, or is that more from a traumatic brain injury?
Well, yes and no. It's not that it causes it, but whatever the causative agent that's causing your increased ICP, so whether it's cerebral edema or blood, you see more of a shift with blood, because a cerebral edema would take a while to get a shift. So, you have half your hemisphere on this side, half your hemisphere on this side, but if this side's bleeding, it's going to start to compress over onto this side. So there are two hemispheres, but there's no brick wall in between the two. And so it's going to start pushing on this. And so that's what they call a shift. It's actually starting to push on the other side. And so you're building up pressure from the increased intracranial pressure. So the one side's getting compressed because it's building up pressure, but the other side's getting compressed because it's getting squished. So blood flow can't go through the other side, the small side, because it's getting squished. So you actually have decreased blood flow from both sides. One because there's too much blood flow, one because there's too little blood flow. But that's what they call a shift. And all that's saying is it's bad. It's real bad because you're having a shift. You're just having so much pressure on one side that it's shifting over to the other side. So it's still a problem. There's still a buildup going on. And so that's bad. And if they can't stop it, if they could have stopped it, they would have stopped it. And if it's still there, then typically it's often, not always, but it's often saying to them, this is a lost cause. Not always.
Thank you.
But often it is. When they see a shift, they kind of say, don't do a lot of effort here. There's not a lot we can do. Not always, but often. Who else? Anybody? Okay, Jade will be here this afternoon at noon. She will start at noon, so plan to be here at noon, okay? All right, y'all, bye-bye. Take care. See y'all next week when I'll be doing trauma. We'll start on trauma. Bye.